I'm Rob Archuleta, Chief Innovation Officer at Crossroads Turning Points, and I'm here with
Jessica Alfaro. I am the lead supervisor of the residential programs at Crossroads.
So today I know there's a lot of changes, and I thought I'd kind of interview and talk to Jessica about the changes with assessments, the ASAM. Before we go any further, Jessica, what does ASAM even stand for?
ASAM stands for American Society of Addiction Medicine.
So the ASAM assessments, the American Society of Addiction Medicine assessment, and the changes that really are happening across the whole state of Colorado. And so this video is hopefully going to go out to all our referral sources, and it'll provide them some information and just some direction and guidance to how to make referrals and just why there has been these changes in the field of addiction. So Jess, how do you feel? We know this has kind of been intense. How are you feeling about it? What do you see as positives with this change?
So I think there are a lot of positives with ASAM. One of the main ones is it really levels the playing field for a lot of clients to come into treatment. There's been a lot of missing abilities for clients to enter treatment that they desperately need for lack of a payer or lack of funding to be able to provide their ability to enter treatment. And so Medicaid really helps open that process up for a lot of people that didn't have the opportunity.
So let's backtrack a little bit. I might have forgot to mention this. So the whole reason we're doing this is because there's been a Medicaid expansion. And so now Medicaid is covering residential treatment for the first time. And so with that, I know there's a lot of confusion about the difference between historically and traditionally SUD treatment, substance use disorder treatment, has been program driven. So if a client comes in and a referral source calls or the client calls, they go, I need 30 days of this program. I need 30 days of residential. I need 30 days of, co-occurring program. But now it's moved to being client driven, which means that the programs aren't what's driving the treatment. Now it's the client's needs, which is why the assessment has become so important. What are you seeing when it comes to client-driven treatment? How do you think that it's been better?
So the client is able to move at their own pace. I know with a 30-day treatment program or a 45-day treatment program, we have to, in some instances, increase their movement for progress. And now a client has the ability to move at their own pace, to be able to process things in a slower pace, at a faster pace, and not have to be stuck in that 30-day process. If they finish early, they finish early. If they need more time, they have the ability to get the time that they need.
Yeah, so we're actually seeing clients, and tell me if I'm wrong, but we're actually seeing clients that will come in like at a regular residential with some co-occurring, but not a lot of physical issues or health issues, come into what we call a 3.5 level of care, which is kind of what the majority of the level of the residential programs are. But we're seeing them for the first time, either if we see that they have more issues, move up to a 3.7, which is a level of care that has a co-occurring component and some health, because there's medical staff at 3.7, and we'll go into that a little later. But they're actually going to a 3.1, which is a TRT, right?
Yes.
And so then they could go out in the community and find a job, and so I really like that you're bringing that up. We're moving at the client's level, the client's pace. So how has this affected our referral sources? And I know this is a touchy subject. So besides just taking the soda bottle and shaking it, how has this affected our referral sources and our referral process?
So I think besides the obvious of the very shaken soda bottle, I think that it's going to take a little time for referral sources to kind of wrap their mind around. But at the same time, this opens up for some of those clients that really do need more treatment to make it through several different levels of care and be able to hit those levels of care as they need it. And so right now, I think it's really big to educate as many people as possible so they have the best information to make the best decision. But at the same time, these clients that are coming into treatment, it is all based on their own progress. And so they will be able to make it through and do what they need to do, and they buy in better into these programs.
Yeah, so the difficult thing is, like, say if I was a DHS worker or probation officer, I used to say, my client's ready to go right now. They're here in my office. I'm sending them right now, and let's get them into 30 days. I know that process is slowed up. So
Yes.
tell us what that process looks like now. How does that look? So the client's in my office. They're like, I'm ready to go to treatment. It seems like there's a stall. What's good and what's bad about that?
So the stall comes from the placement assessment. And so a placement assessment is an assessment that's completed so that we can make sure the client is, based off of the information they're providing, going into the appropriate level of care. So when they don't go into appropriate levels of care, sometimes we get clients who are more resistant. They sometimes have earlier relapses than they're prepared for. And so when they go into a level of care that they're prepared for, they usually buy in more to that program and they want to learn at that pace. And so that has been the slowing process, is that we want to make sure that they're going into that appropriate level of care. Sometimes it isn't the level of care the referral source thinks they need or wants them to be in, but it's...
What that means is the probation officer or the DHS worker, a good reminder of this also is, yes, there's a bit of a stall, right? But we're getting the client in the appropriate level of care is what
Yes.
I'm hearing you say. But also I think it's important to remember most of our clients are going to need some kind of withdrawal management service. And so when they come into withdrawal management or detox, as us old school people call it, when they come in for that, what we'll be able to do is we can get their own assessment done, and we could get that assessment done even while they're in detox. It just, the level of care may not be residential. It will be whatever the client truly needs, correct?
Yes, absolutely. And that really helps the client feel like they have more control. And, I think that's the best thing for a client who is probably been out of control with their addiction and their life has been truly unmanageable through a very hard addiction, depending on the client. And so the more control that they feel like they have, the more that they are going to want to continue that process.
Yeah, I think it's important to mention too, like these clients are getting assessed and they don't know necessarily what they want sometimes, and then other times, while they're in treatment, they're gonna realize I need more than this, or I need less than this, or I'm better than I thought, or I'm more motivated than I thought.
Yep.
And so I think this process, although it's been hard, the rollout was very difficult. We're hoping that you could take this video, share it with referral sources, and they'll truly have an understanding of what we're doing, what our goals are, why there's been this change. The great thing is, like you said, it levels the playing field. Now people don't have to wait till they're on probation or parole or have a baby to get treatment. Now the people that need treatment are getting it. Medicaid has made that possible for us. And it's also, somebody said to me one day, they said, so now Medicaid and payment is driving treatment. And I think it's important to say, yes, Medicaid is driving the treatment, but Medicaid is really giving approvals based on the clinical documentation that we give them, so the client is still in the appropriate level of care. So can you talk about what that looks like when the client's in treatment and now you're asking Medicaid, hey, can we keep them longer? Where do they need to go? Can you tell us about that?
Sure. So we submit for a prior authorization, and the Medicaid approves, usually for the first week or two, depending on the client. And so they want a reassessment. They want to know what kind of progress the client has made in the first week or two. And that is where that client-driven piece really comes into play. If the client is still foggy from withdrawing from the drugs that they were on, it allows the client to have a slower pace, to learn those skills that they need and be able to practice them as they're learning them. And so after 2 weeks of the first part of their treatment program, we reassess. We ask the client how they're feeling, how things are going, what they're learning, and we take their behaviors into account and how their behaviors are reacting to the changes that have come upon their life as newly sober people.
So I want to wrap it up. I want to make sure that we give our information. So if you have questions about what's going on, or there's something that we can help you with at Crossroads, or even help you point you in the right direction, my email is rarchuleta@crossroadstp.org.
And my email isjalfaro@crossroadstp.org.
So I know this has kind of been a rough rollout. I think in a year from now, we're going to see a lot more clients getting services. I think this is a positive thing. Change is always difficult, but in the long run, in the grand scheme of what we're doing, is we're creating a client-driven treatment model that probably we should have been using for a long time.
Absolutely.
It is hard to wrap your mind around concepts. When professionals feel like, but I know what's best for the client, I know what the client needs. This is kind of us really letting the client dictate what they want and what they need. Jess, do you want to add anything to this?
No, I think you make a great point, really, and it puts the accountability back on the client. The client is as motivated as they're going to be, and so if they're going out and getting those placement assessments completed and they are moving through the process as it's needed, it allows them to be accountable but also have that control that they very much need.
So hang in there, guys. If you have questions, contact us. Let us know what's up, what your questions are, and we'll do our best to point you in the right direction or just give you any information that we have. Hang in there.